All right, thank you, everyone. Thank you for coming to this symposium. This session is going to be about how much is too much, taking on the challenges of costs of CF care. And I'm extremely excited to be here today and to be here with my co-moderator, Jamie Wooldridge. Jamie's a professor of pediatrics and a pediatric pulmonologist at the University of Rochester Medical Center, and I'm Ryan Perkins. I'm an instructor in pediatrics and an adult and pediatric pulmonologist at Boston Children's and Brigham and Women's Hospital. And Jamie and I have no disclosures related to our conversations today. And I think with the people in the room here today, I don't have to convince you that over the last decade or two, there's been a lot of improvements in health outcomes and considerable innovation that's transpired in the care and treatment of people with cystic fibrosis. And I remember very fondly back to 2019 being in Nashville when we got word about the approval of ETI and excitement about the possibilities and the potential for people with CF. I think we've all seen newspaper articles, headlines like this one from the Boston Globe describing people with CF that we take care of and the impact that ETI has had on their life. And in fact, when we look at registry data, we see that there's been significant improvements in lung function across the ages over the last 20 years. And if you look at the panel in the upper right, we see that there's been considerable improvement, nearly doubling in the median predicted survival of people with CF from 2002 till today. And when we think about exacerbations and those requiring IV treatment, we see over a 50% reduction just in a 5-year period of time. And excitingly, we've seen a tremendous increase in pregnancies over the last 5 years as well. And so with all of this going on in this new era of modulator therapy, the cost of CF care has grown substantially. And this has raised questions, though, about cost effectiveness and the affordability of care. In particular, the Institute for Clinical and Economic Review did a study in 2020 that looked at the effectiveness and value of highly effective modulator therapy. And this is a table from one of their reports. Just to orient you a little, the first column includes the modulators that were included in the review. The second column includes the wholesale acquisition cost for these modulators. The third column is the annual price that these drugs would have to be lowered to meet the cost effectiveness threshold. And you can see that they're really not anywhere close to what the wholesale cost is. The fourth column shows the percent reduction that would be required to meet the threshold price. And you can see for many of these drugs, this is a reduction of around 75 to 80% of the wholesale cost. Over this same time period, though, there's been a lot of interest in healthcare utilization patterns and cost, and there's been several papers published about this. And following the approval of ETI, there's been more recent papers that have come out that have questioned the cost of these medications and what that price has done for people with cystic fibrosis. In addition to this, though, over the same 10 to 20 year period of time, there's been a lot of changes that have transpired from a policy perspective. And so in 2010, we had the passage of the Patient Protection and Affordable Care Act, which created significant changes in payment structure for healthcare. We'll hear a little bit more about some of those changes in one of our talks today, but in particular, it led to the creation of the Center for Medicare and Medicaid Innovation, which has sort of led the way in developing some of the alternative payment models that you'll hear about. Additionally, ensuring access to affordable care and striving to eliminate disparities in healthcare outcomes have shaped the landscape for investigative, policy, and advocacy efforts for care related to people with cystic fibrosis. And so from this session today, there are really 4 areas that I hope that you will be able to see and sort of grasp onto and leave this session knowing a little bit more about. The first is to be able to identify current financial models that are supporting CF care centers. The second would be outlining new models of value-based care. The third is to identify the impact of third-party payers on access to care. And then finally, demonstrate the ongoing efforts to ensure appropriate access to high quality and affordable care. And to sort of lead the way in doing this today, we have a wonderful panel of speakers who will speak to you. They all have expertise in these particular areas, and we're very thankful to have them today. And before we get started, just a little bit of housekeeping. Instead of having each of the speakers come up and then doing a question and answer session immediately following, we'll have all of our speakers give their talks and then have them come up and do a panel type of discussion. If you have questions that come up in the midst of their talks, I would encourage you to enter those into the NACFC application. If you're not sure where that is, if you look in the bottom right section here, if you click on this, there's a spot to do the question and answer. And so without further ado, we'll have our first speaker come up. Our first speaker today is going to be Dr. Peter Magazel. He's the Minowitz and Rosenstein Professor of Pediatric and Respiratory Sciences at Johns Hopkins School of Medicine. He's the director of the CF Center and the Division of Pediatric Respiratory Sciences at Johns Hopkins. He has extensive experience in providing care for children with CF, and he's been involved in the CF community for over 25 years. He's chaired numerous committees. He's a past chairman of the CF Center Committee, and with all of these experiences has multifaceted perspectives on CF care. And so today he's going to speak with us about the business case for CF care.
Well, thank you for that very kind introduction. Do that. So I have some disclosures, but they're not related to this presentation. We're going to talk today about the challenges facing the current care center model from a financial standpoint, talk a little bit about developing a business plan to how to support the finances that we have now and in the future, and talk about pharmacies that may be able to help you in the form of a 340B pharmacy. So the current landscape of care is changing. We're going to talk about some financial basics, creating a business plan, the pharmacy, and then give you a real-life example of what this might look like. So 25 years after the description of CF by Dorothy Anderson, a new approach to care was advocated by Leroy Matthews in Cleveland. Multidisciplinary care and specialized centers that took an approach that was preventative and aggressive to try to improve health. This idea was championed by the CF Foundation and led to the creation of the CF Center Network. There were guidelines created that over time were refined based on evidence. And this approach, as you just heard, has been remarkably successful. Survival has improved dramatically since it was first described, or since CF was first described in the 1930s, and life expectancy was 2. Now we have an accelerated success with modulators. This approach has been made possible by the care team model that's in place in all the centers in the United States. There are required members of a team that are supporting a patient and family, including a physician, respiratory therapist, dietitian, social worker, nurse, program manager, many teams of other core members that support this team, and then other specialists in both pediatric and adults that really make the center function. The CF Foundation, as part of their staffing guidelines for accreditation, has determined that an optimal staffing is 1 clinical FTE of each of the essential roles for every 100 to 200 patients. And this is where the problem comes in. How do we support this care? We have to remember, though, that not all CF programs are the same. There are pediatric and adult and affiliate programs. They're geographically diverse. They're in different care settings. And they're different sizes. As illustrated here, you'll see the size of the dot represents the size of the center, or the size of the center population. Most centers are between 50 and 200 patients. And you can think of this in kind of 3 groups. Larger centers where they may have so many patients that outstrips the ability of their FTEs. or in smaller centers that don't have enough patients to really justify having full FTEs for support. It's kind of like Goldilocks and the Three Bears. Some are too small, some are too big, and some are just right, at least for funding. We have to remember that the landscape is changing, as you already heard. Survival is improving, and it's accelerating dramatically. And as survival improves, that means there are more patients. This is an illustration over the past 3 decades looking at pediatric patients in the green, showing that there's a stable number. This is a genetic disease. The same number of people are going to be born every year, but there are more and more adults as people are living longer. And projections show that this is going to continue well beyond where we are in the 2020s for decades to come. And as we have more patients with cystic fibrosis, especially more adults, we have to remember that the patient population in general is getting healthier, but not for everyone. These are pie charts showing lung function for the year 2000, where we are right now in the 2020s, and then 20 years from now. The green is minimal lung disease, or normal lung function, or minimal lung disease in the blue. And as we go along in children in this top row, there are more patients that are healthy. This is also true for the adults as well, but there's still a significant number of people with moderate and severe lung disease. Looking at this in a different way, you can see in 5-year increments in a projection that as we go along, there are the same number of children, but they're getting healthier. In the adult world, people are getting healthier as well, but the population is growing with a number of people with still moderate and severe lung disease. As the population gets healthier, people get sick less often. This shows you exacerbations for different age groups over the past couple of decades. And you can see a dramatic drop here in 2019 and 2020 with the introduction of elexacaftor, ivacaftor, and tezacaftor, but also overlaid with the COVID pandemic. But even as COVID has receded, the decrease in exacerbations has continued. So what does this mean for a CF center? This translates into fewer visits. This data looks at the number of visits per patient. Over the past several years, it had been pretty constant between 4 and 5 patients. Starting in 2020, the number of visits per patient decreased, and the type of visit changed from the in-person visit in blue to the telemedicine visit in green. If you look at the total number of visits that are occurring, they're staying relatively constant, though. There is this big shift here in the COVID pandemic where there's more telemedicine and less in-person, and it's now flattened out with about 3/4 of the visits being in person and 1/4 being telemedicine, but about the same number total as there was a few years ago. This is because the adult population is growing in size, even though the number of visits per patient is decreasing. In my practice, the number of visits has dropped dramatically in pediatric patients that are getting healthier. So this is really good for patients, but is it good for CF centers? Because fewer patients mean less revenue. So one way to look at this is, what are insurance companies paid? What are we getting paid for our services? This is a study looking at 494 commercially insured patients in the 6 months prior to the introduction of elexacaftor, tezacaftor, ivacaftor, or ETI, and the 6 months after that. When they look at inpatient costs and total medical costs, there's a dramatic decline. So the introduction of a highly effective modulator to a significant decrease in payout for medical care, for inpatient care, for ER costs, and for total medical benefits. At that same time, though, there was a significant increase in pharmacy costs, where you went up over 5-fold, really driven by the new modulator. Now, this is not good for insurance companies. It might be good for CF centers in a way, and we'll talk about that in a little bit. So what's the business case for cystic fibrosis? That's the title of my talk. It's a way of figuring out an approach to financing CF centers, or presenting that to people. So the goal of this is to empower CF program leadership to understand your finances, inform leadership about the value of the CF program, to provide insight about the program and operations to leadership, and to create a financial model to support not only the current, but also the future needs of people with CF and their families. So the place to start is to try to understand where your CF center fits within the bigger picture of your medical organization. So if this is your CF practice or clinical practice in a medical school and a hospital, how are they interrelated? Are they all independent entities as shown here? Is the practice integrated with the medical school? Is the practice integrated with the hospital? Or perhaps all three are integrated in your organization, such as Johns Hopkins, where I'm from. So to understand the finances, you first have to identify people in leadership that are interested in the finances. You have to identify people that can understand and provide the numbers for you. You have to think about what the sources of income are, what the expenses are, and how should revenue be allocated and expenses be allocated for people that are beyond your immediate center, beyond the doctors and nurses that may work in your office. So the team has to interact with, the leadership has to interact with administration from the hospital, from the practice, from the School of Medicine, grants administration, we all get CF Center grants, and then financial people that can help you with the numbers and the analysis. So the place to start is financial performance. Financial performance is profit and loss. Do you make money? Do you lose money? So you have to start with revenue, all the revenue that comes in, again, beyond just what you see in your clinic. What happens in the hospital, in the pharmacy? All the components, all the payers, and all the revenue. Remember, your CF Center grant plays into this as well. And then what are the costs? The personnel, the medications, the supplies, the administrative costs. If you subtract the costs from the income, you get the contribution margin. That's your profit or your loss. That's the way I think about it. But leaders in your organization may think of it a little bit differently. They may add in overhead costs, depreciation, corporate overhead, IT, all that stuff that's behind the scenes. If you subtract that from the contribution margin, you get the operating margin, or what's called the fully loaded costs. So for your clinical practice, we're talking about the physician charges, the team charges, the clinic charges in the outpatient setting, all the inpatient charges, the testing, imaging, and then things beyond that, downstream revenue. What are other specialists doing or getting out of your program or from your program? ED visits, surgery, pharmacy, home care if they're part of your organization. The typical approach to a business plan is illustrated here. There's a narrative. It summarizes the need, the impact, the justification for the request, the income statement, the profit, the loss, the pro forma, what's going to happen in the future, incremental volume, incremental changes in finances in 3, 5, or 10 years down the road, and other downstream impact. Does this change quality, improve capacity, satisfaction, reduce length of stay? There's a lot of things that are going to happen beyond just what you're doing with dollars and cents in your clinic. This may be a little hard to see in the narrative, but the idea is to provide some background, talk about your program, what are the accreditation requirements, changing care landscapes, define the need. What do you need? Is it money? Is it space? Is it personnel? Provide information. Why do you need it? What is it going to cost? And then what happens if you don't get that? What's the impact? How is this going to change what you're doing right now? And then how does this align with the organization and the mission of your program as it aligns with the organization? And some other things to include beyond money. We talked about these already: discharges, patient days, length of stay. For the doctors in the room, RVUs. These are all things you can talk about compared to a budget, compared to last year. How are things going to change? The pro forma, what does the future hold? Expenses, volume, revenue, and other benefits. Again, clinical outcomes, patient satisfaction, operational efficiencies. I mentioned pharmacies a minute ago, and I wanted to take a minute to step back and talk about a 340B pharmacy and what that is. This is a program started in 1992 to help vulnerable, uninsured patients served by safety net facilities to get medicines at a discount. The facilities can then use that money to support the programs. And eligible healthcare organizations, or what they're called covered entities, are defined in the statute, and they include Medicaid and Medicare disproportionate share hospitals. So hospitals that see a lot of Medicare and Medicaid patients, as well as children's hospitals. That's where CF patients are seen. The whole idea here is, in a very simplified way, the pharmaceutical company makes a drug, sells it to the hospital dispenses it to the patient. Because they're getting it at a discount, when the insurer pays the full price, the hospital gets a bigger profit. So there's a $100 drug that the insurance company is going to pay for. You get a discount. The patient may pay you something, so there's a profit at the end to support the programs. Eligible prescriptions for a 340B pharmacy are ones that are on the formulary, They have to be given or written by a prescriber that's in the covered entity, working at the covered entity. So this is typically hospital-based clinics. It has to be an eligible patient that's cared for at the pharmacy and not subject to other discounts. There are lots of covered entities, but we're really just talking about two: children's hospitals and hospitals that care for people with Medicare and Medicaid. So how do you actually go about doing this? Well, you have to think about the challenges first, right? Locating the right people, educating leadership and the finance people about what the goal of the program is and why they should even bother doing this. Isolating the CF finances from other things in the divisions, sleep, pulmonary. Remembering that people are busy and it may take a while for you to get this data. And it may not be a priority for leadership. So you really need to convince people that this is important. And we'll talk about potentially a way to help with that. So a real-world example. These are numbers from Midwest centers that it's an academic center, big hospital, close to 1,000 beds. It's an adult program, 300 patients, 7 doctors, only 2 clinical FTEs, so people doing research or administrative things, an inpatient NP, a whole team, and actually a dedicated 18-bed hospital ward. So when they looked at their money, pooling everything together from the organization, their physician practice lost money. They brought in $300,000, they spent $600,000 on what they needed to do. But that was offset with what the hospital was making. They brought in $21 million and only spent $15 to make a $6 million profit. A lot of this was from the pharmacy, because they do have a 340B pharmacy, but if you put it all together, it's a $5.7 million contribution margin. As I said, though, leadership looks at operating margin, so if they took out their overhead, they were still at a $3.1 million profit. And what you'll say now is, well, this is all because they've got a pharmacy. Well, actually, that's not true, because if they take out the pharmacy, they make less, but they still have a $1.2 million contribution margin and a little bit more than break even in operating margin. So it is possible to make money. Not everybody's going to make money, but you certainly can do that and figure out where you stand. But times are changing, and this program has seen an increase in revenue over time, but it's changing from their inpatient revenue here in blue has dropped off dramatically, where their outpatient revenue, which is where the pharmacy is included, is increasing. So after you create all this, what are you going to do with it? Well, you have to make a pitch, right? You need an elevator pitch for the leadership. You need to highlight the achievement. You have to be excited about this, what you're doing for the community and the patients. How does the success of your program benefit the leadership's interests and the mission of the institution? Remember, when you're talking to leadership, every conversation should not be a request for money. You should be talking to them about your program and the successes that you have. And you shouldn't be going there and complaining about things too much. So a little bit's good, but not too much. Come with solutions, not just a handout. Remember that they have a lot of people coming to them asking for money too. So they're not your enemy, and when they say no, there may be other priorities that are more pressing. That's why you need to go back again. So I hope at the end of this there are some myths no longer. Physicians are not necessarily interested in finance. Really isn't true. We need to be in this day and age. CF program does not exist independently. It's part of a bigger organization, and you have to figure out in your program how that organization is structured. It's not necessarily a money loser. Institutional leaders do care about small programs like CF, which can really be showcases for what they do and what they accomplish and the mission of the program and of the institution. So thank you. I'm glad I got a few minutes to talk to you about this, and we'll have questions at the end.
Thank you, Peter. All right. Our next speaker will be Dr. Jamie Wooldridge. Jamie is a professor of pediatrics at the University of Rochester Medical Center. She continues her long-standing work for improving outcomes for children with asthma and CF through quality improvement. And this work led her to a new interest in value-based payments and population health. And because of this, she sought to better understand these fields and decided to complete a master's program in population health. So she's currently finishing that up later this year. Her lecture today, though, actually comes out of the learnings that she's gathered from that master's program. So Jamie today is going to talk with us about value-based CF care.
Okay, good afternoon. So, healthcare payment reform. Now that Peter just told you all about how to do it, now I'm going to tell you about how you need to start thinking about it for the future. And the future is going to be much sooner than you may realize. Okay. For this lecture, I have no disclosures. So what I'm going to do over the next 20 minutes is I'm going to review with you the goals and timelines that are currently in place lower that a little bit, for healthcare payment reforms. We're going to walk through so that you can understand how and why the Center for Medicaid and Medicare and Medicaid Services is driving these reforms, both what their previous role is and what their role for the future is going to be. I'm going to give you a brief overview of what the different payment models are, and I'm going to do this in a way with actual numbers, so hopefully it helps explain it. I will give you a little bit of a disclaimer in that it took me a good 8-week course to figure this out, and I'm going to try to teach you in a few minutes. So if I don't do it, please ask questions or come up and talk to me afterwards. And what I really hope that you get out of this lecture is the critical role that we need to play as providers and healthcare teams for shaping this reform. We are at a junction right now that it is not too late. We can get involved. We can help drive these reforms to make sure these reforms meet the patient needs of our patients and for ourselves and our care teams. But if we don't, we're going to, unfortunately, I think, see a situation of more burnout and moral injury. Okay, so there's a basic premise that all of the healthcare payment reforms are based on. And that is that in the United States, and I'm not talking about just CF care, I'm talking about the whole healthcare system, it costs more in the United States to provide care to the population than any other developed country across the world. However, we spend a lot of money, but if you look at our major healthcare indices, such as overall mortality, infant and maternal mortality, major outcomes for things like heart disease, we have a population that is dying, that is much sicker and dying sooner. And I'm not here to debate that. If you've got any questions, you can go to this website, the Organization for Economic Cooperation and Development, that has a lot of the data to support this. So let's talk about the Center for Medicare and Medicaid Innovation, or CMMI. So CMMI was developed as part of the Affordable Care Act of 2010. And a lot of people, that act got a lot of publicity about all of the developing, like the marketplace and requiring healthcare insurance and things like that. This was a small but very important part of that act. And what the CMMI was established was to design, implement, and evaluate new payment models. And these payment models are supposed to be focused on 3 specific things. Focused on equity. It's supposed to be patient-centered, and patient-centered as meeting patients where they are, and based on value to the patient, not volume of services provided. Every decade, CMMI gets about $20 billion, excuse me. And so you can see they are well-funded to support the work that they're doing. And here's an important thing to know. So during the 2010s, so the last decade, CMMI did what I call kind of the threw the spaghetti on the wall method of they picked 50 different kind of payment reform models and used different centers and healthcare groups across the country. They did it in academics, they did it in rural health, they did it across the real spectrum, and tested these models to see what worked and what didn't work. And they learned a lot from it. So that gets us to their goal for 2030. The goal for 2030 for CMMI is that all Medicare and the vast majority of Medicaid beneficiaries, our patients, will be in a care relationship. And a care relationship means a payment model or a contract or their insurance coverage that includes accountability for quality and total cost of care. Now, who's accountable for quality and total cost of care? We are. By 2030. It is 2023. And wherever Medicare and Medicaid go, commercial payers usually follow. And commercial payers across the country are starting to look at this and do some of this contracting already. So we cannot let the administrators define what is quality and how much care should cost. Thank you. This is our opportunity to get to the table to be part of these negotiations and part of these contracts. So what I hope to do now over the rest of this lecture is to give you a little bit of a foundation of what these models look like. Okay, so when you're thinking about value-based payments, let's talk about the ideal, okay? And then what we're going to do is in detail talk about all four of these categories. But what is the ideal payment model that we would all like to work under? One, it's patient-centered care. The patient has the ability to receive the services that will best address their specific health needs, but also not receive unnecessary care. And the patient is assured of receiving appropriate evidence-based care. The healthcare provider gets to receive, our teams get to receive the support we need to deliver this type of high quality, efficient care. And there's transparency. Patients can select who they want to have take care of them based on quality and cost of care that's delivered. Now, you may read this and go, well, we do that in CF, because we do. And we're one of the leading models for that reason. The CF Foundation and the community, long before the Affordable Care Act went into place, has worked to achieve this goal. But the thing is that do we achieve it for our kids with asthma? You can tell I'm a pediatrician. Do we achieve it for our patients with COPD or any of the other chronic illnesses that are out there? This is where healthcare payment reform is trying to go. So let's talk about category one. So Peter just did a great job of talking to you about how to function in the current fee-for-service world. The difficulty is fee-for-service is going away, and it needs to go away in my opinion. So fee-for-service is basically, I provide a service, I see you as a patient, I submit a CPT code, I give you the diagnosis, and you then pay me. And who pays you is whoever the insurance company is. It's based on volume, okay? So the more you see a patient, the more money you generate. We all know the struggles that really important services usually aren't covered or you can't get any billing for, and that's like the importance of our social workers, our nutritionists, our respiratory therapists, just to name a few. It's difficult to assess quality of care, okay? If I had COPD, I'm not like a CF patient. I can't go to the CF website and say, well, what are the places that provide the best care? What are the doctors who are going to help me stay out of the hospital and help me stay healthy? That's a benefit that we've been providing our CF patients for a long time. There's no assessment. Also, we get penalized for keeping our patients healthy. If we keep them healthy out of the hospital, maybe if we keep them healthy, they don't need to come into clinic as much. but we don't get paid. So for that reason, fee-for-service is going away. So let's get into the second category. This is quality or value-linked fee-for-service. So this is where most value-based payments are happening. And so what this is if you've ever heard of a patient-centered medical home, you may go to your own primary and see something about, we are a patient-centered medical home. And you're like, what is that? So what that is that CMS provides, if you become certified as a medical home, you get extra payments for providing primary care. And I'll give you some specific examples of what the payments look like. This applies to most of primary care services, and I'm sure we all know these CPT codes of 99102 all the way to 9915. As part of this link to value, you can get bonuses for reporting data, and then you may also get additional bonuses for hitting a certain metric in that data. So, as I said, all the examples I use numbers that should be very easy to follow along. They are not real world numbers, okay? So in this second category, let's say you have 100 Medicaid patients assigned to your practice, okay? Because you're a medical home. And because you're a medical home, every time you charge a 99215, instead of the standard rate of $100, you're gonna get $105. So over a year, you see those patients 250 times, okay? And so that extra payment that you get is an extra $1,250 to provide care for those patients. That's a little extra money in your pocket you didn't have before. Now, let's say you also report to Medicaid if those patients get their flu shot. And Medicaid says, okay, thank you for reporting that. We'll give you a little extra money to report that. And then they say, if you can get 90 of those patients to actually receive their flu shot, we'll give you an extra $100 or $500 on top of that. So that's where you get those additional bonuses. So you can see how, okay, this would be a way that I can actually get paid to provide better care for my patients, right? Now, here's a potential downside, is 15 of those patients decline their flu shots, okay? And you've made an investment in nursing time to get them to receive their flu shot so the nurses can talk to them, but you don't receive that extra bonus. So that gets into everything has pros and cons, correct? Okay. So here are the pros of this kind of payment reform is you get higher payments for doing what, for providing the services you have been. However, ancillary services, social workers, respiratory therapy, all of that, as we talked about, is still not covered. If you're not at the negotiation table, the additional payments that you're going to get may not be enough to really help you cover your costs. Who sets the metrics of what's important? That Medicaid says we want all of your patients to get the flu shot. We all know flu shots, so that's a no-brainer, right? But what if they start putting metrics in place and one of the ones I use that gets mentioned a lot is the asthma and medication ratio. Well, in pediatrics, the asthma and medication ratio is a very different metric to use because a lot of kids at the beginning of every school year get multiple albuterol inhalers to have at mom's, dad's, school, aftercare program, all of that. And that completely skews their asthma medication ratio. So in all of this, you've got a lack of control over patient behavior. So you may talk till you're blue in the face to this patient that they need their flu shot, but they still decline. There's also no assurance at individual patients. So if a patient says, I'm part of that 100, but I'm not going to come in, no matter how hard you work, okay? And there's also some upfront investment that you may need to make. So if you're reporting data, you've got to be able to get that data out of your EMR, and you've got to work in a system that can provide that data to you and help you extract it. So, category 3. Shared savings and risk. So this is the one that is the most complicated, but this is the one that we seem to be moving forward with the most. So in shared savings and risk models, what happens is the contract is set up based on previous or expected costs and payments. This expected comes from regional or national benchmarks. There can be risk stratification depending on how sick your patient population is. And frequently it's looked at over what did this patient care cost over the last 3 to 5 years. Okay? If at the end of that designated year, you actually were able to provide care to those patients for less money than expected, that's savings, and the insurance company says, we will share this savings with you. We will give you a certain portion. However, if the actual care of the cost costs more, you may not get fully reimbursed for that extra cost. Now, one of the things you need to know about for the shared savings and shared risk is your accountable health organization or your accountable care organization. This is the best way for you to engage to find out what contracts are getting negotiated. So ACOs hold the contracts with the payers, and that could be Medicaid, Medicare, commercial, okay? Patients are enrolled or assigned to an ACO, and providers are enrolled to ACOs. I went looking and found out I'm part of the ACO for the University of Rochester Medical Center. Had no idea till I went looking, okay? I challenge you to go home and see, are you part of an ACO? And if you are, find out who's leading your ACO. Look at their leadership board and find out how many physicians are on the board. And if you don't see really good representation of the healthcare providers, you need to start talking to your ACO because they're going to be negotiating these contracts. And this is what an ACO does. They establish the contracts. If there's shared savings, they receive the payments. They transfer those payments to providers. And then a good ACO is also going to help providers actually do things like quality improvement initiatives to reduce cost of care and make it of higher quality. So, specific example, you've got 100 Medicaid patients assigned to your practice. You have a contract for 40% shared savings and 10% risk. Based on looking at old metrics of the last 3 to 5 years, risk stratification, it's expected that it's going to cost $500,000 to take care of those 100 patients. At the end of the year, what it actually costs to take care of those patients was only $450,000. So you get 40% of that shared savings of $50,000, which means $20,000 comes back to you. So what you actually get paid is $470 when it only cost you $450,000. You've now got some extra money, and maybe you want to do something like start to support a mental health care provider. However, let's say that those patients have got severe COPD, and their actual costs of taking care of them because they had lots of sick visits was actually $550,000. So it costs more than the expected $500,000. The insurance company says, well, you had 10% risk, so you have to cover 10% of that loss. So what you actually get paid, it costs you $550,000 to provide care, but you're only going to get reimbursed for $545,000. Now, you can have contracts where there is shared savings only, but the percentage of shared savings is usually around 10 to 20%. If you want that higher shared savings, you've got to be willing to take on some risks. Now, pros and cons. Payments can fall short of cost of delivering care. This is where your contract negotiation becomes so critical. It's the same kind of cons, no absolute assurance that individuals are going to receive quality of care. You're, again, and we all experience this, lack of control over patient behavior. There are ways to work around this, and that sometimes you can start spending money to avoid losses instead of actually delivering care. Or you can actually start saying, okay, well, we're supposed to see these patients 4 times a year, but we're only going to really see them 3 times a year because then that's going to save us a whole bunch of money. But is that really taking care of the patients? So you have to be careful of this. And then let's get into the big one, capitation, and I am keeping an eye on that. So capitation is, in my opinion, where I would love to be. So the first thing I want you to notice is it replaces fee for service. The fee-for-service payment, okay? So with capitation, there's no need for bills. There's no need for charges to be completed, okay? All of us who are documenting, and we have to include this specific partner note and that specific partner note to be able to get billed for what we're doing, that goes away. Now our notes only become about what we need to do to take care of that patient, okay? That's one of the exciting things about capitation. So how do you make money? Well, you make money because it's figured out. You get an upfront per member per month payment, okay? These payments are based on expected costs. And then how you spend that money and what you do with that money is much more up to you. Now, the risk, if the costs go over what you're getting paid, is 100% on the healthcare providers. And just so you know, there are different types of capitation. There's condition-specific, population-based, integrated finance, delivery systems. And if you want to go to the CMM, or if you want to learn more about this, go to the CMM website. So here's a great example. So let's go back to those 100 Medicare patients assigned to your practice. You get paid a per member per month payment of $416 for an annual total of $500,000. What it costs to run your practice. You need $350,000 in salaries for your physician, your MP, your nurse, your social worker, your dietitian, and your educator. It costs you $50,000 for all your building and overhead, and then you also need $50,000 for supplies because you do a lot of in-office testing. So your total costs are $450,000. So you're getting an extra $50,000 that you can invest in new services. You know, now you can get that mental health care provider, a good portion of them, to help with behavioral issues or mental health care or things like that. Now, let's say that 20 of the patients have severe COPD. You get an unexpected number of phone calls and sick visits to cover that. You have to hire a new provider and a nurse. That's additional salary of $150,000. So now your cost to provide that care is $600,000. That's a loss to you and only you of $100,000. So this is where negotiation is so critical, because it's at negotiation that you determine what your payments are going to be. So shortfalls. Cost of delivering care is more than expected. Again, lack of control over patient care. And that last bullet point of investors, vendors, and financial intermediaries can profit. So that's an example of, let's say you hire somebody to do your diabetes education, an outside company, but you find out that they're really not educating your diabetics like they need to be educated, and so your diabetics keep having medical care costs. So that's one thing you have to look at, and that's these third parties are definitely a big thing that's up and growing. So in summary, CMM is driving these major changes in healthcare over the next decade. It's got the potential to be very beneficial to our patients and to us, but it's also got the potential to be very harmful to us. And so it's now is the time that we need to be fully engaged. And if we don't engage, we leave our patients and ourselves at risk and for potentially unsustainable risks. So thank you.
Thank you, Jamie. All right, our next speaker will be Dr. Cameron McKenzie. Cameron is a clinical pharmacy practitioner at the University of North Carolina Children's Hospital and Pediatric CF Center in Chapel Hill, North Carolina. Dr. McKenzie serves as the residency program director of the PGY2 Pediatric Residency Program at the UNC Medical Center. Additionally, she's a clinical adjunct assistant professor at the UNC School of Pharmacy, and today she's going to talk with us about navigating insurance issues, access, and cost.
the short one, apparently. All right. And start. Okay. All right. Well, first, thank you to both of you for inviting me to speak. Today, I'm going to do my best to discuss payment and access to CF therapies, specifically focusing on the impact of payer and third-party programs and related to patient access. Here are disclosures, although not related specifically to this presentation. So in the next few minutes, I hope to accomplish 3 primary goals. First, we'll briefly review the most common types of both pharmacy financial assistance and copay adjustment programs, since I imagine each center's experience is a little different based on lots of different factors, mostly out of our control. Second, we'll analyze some of the recent literature that was touched on earlier, as well as some other studies related to the cost of CF care, as well as briefly mention some important legislative and judicial updates. And then finally, I'll close with some considerations for addressing patient-specific factors related to medication access. Unfortunately, I left my magic wand at home, and there aren't easy answers to most of these questions related to this topic, but I think our collective experience and our creative thinking of our care teams can hopefully continue to help us navigate this landscape. So we'll start with types of pharmacy assistance available. Many of you are likely familiar with these, but just to sort of set a level playing field. So first, manufacturer copay assistance programs. These are funded by the manufacturer of the medication, and they offer patients with insurance coverage financial assistance for specific medications after insurance has paid a portion of the cost. These do typically exclude uninsured patients and those with federal insurance, and they may or may not have income criteria as part of their qualifications. One nice thing about these programs is that they can usually be adjudicated at the time of medication dispensing, which alleviates some of that cost burden to the patient. Next, we have manufacturer patient assistance programs, which makes it really confusing, but sometimes they're referred to as PAP programs. These are typically aimed at uninsured or underinsured patients. These programs provide patients with medication free of charge through an internal program. Many of these programs do have financial income criteria, though unfortunately most of them are not particularly transparent about what those eligibility criteria are, which creates a challenge for care teams and patients. And then lastly, there are third-party assistance programs. So these are often separate grant funds that provide additional assistance on top of potentially a manufacturer-based program, and they can also in some cases provide assistance for medications that don't have manufacturer-based programs. These almost always are going to have income eligibility criteria, but most of them are insurance agnostic, so we can also potentially utilize these for our patients with federal insurance. Oh, there we go. So next, copay adjustment program types. So there are 3 main types here. First, copay accumulators are programs that exclude copay assistance from applying to the patient's deductible and out-of-pocket maximums. These programs take the stance that out-of-pocket should truly mean out of the patient's own pocket, and so any funding, whether that's manufacturer-based or a third party, is not applicable, although they certainly still take it. Copay maximizers utilize cost sharing that enables the insurance to maximize the assistance available from a manufacturer throughout the calendar year. These also do exclude that copay assistance from applying to the patient's deductible and out-of-pocket maximum. And then last, my least favorite, alternative funding programs, or AFPs. These are sometimes referred to as specialty carve-outs and unfortunately are becoming more common. So in these programs, specific medications or medication classes are excluded from the patient's plan altogether, and then this external AFP vendor assists the patient in applying for either financial coverage or free medication to alleviate the cost burden of the insurance payer. While currently a small percentage of employers use these, a 2023 survey indicated that close to 10% of employers say that they do plan to use these in the next 2 years. There we go, okay. So here is a list of some of the more common AFPs. often they don't specifically call themselves an AFP, and so it can be helpful for us as care teams to have a sense of what these programs are so that we can help our patients and families identify them within their own insurance plans. So given those definitions, let's walk through an example. So in this example, there we go. If the patient had a traditional insurance plan, you can see that the copay assistance in January at the start of the insurance year pays as much as it is allowed, so $2,000 in this case, which means there's no residual cost to the patient. Now, we all know that we don't have many $2,000 medications in the CF world, so likely in real life, the insurance plan would also be picking up some cost here. But for simplicity's sake, after that, the patient would have met their deductible, and then each month the copay assistance would cover $200 of the remaining cost after the insurance paid until December. At that point in December, the patient has met their out-of-pocket maximum because in a traditional plan, that copay assistance applies to that, and the insurance picks up the entire cost in the last month of the year. In the situation of a copay accumulator, however, you can see that the copay assistance is paying the maximum amount that it is allowed to per month of $2,000 until the entirety of this particular copay assistance problem, which has a $12,000 per year maximum, has been used, which happens after June of the calendar year. Since at that point the patient themselves has not paid anything, now they are responsible for $2,000 in July to meet their deductible, then the leftover $200 after that each month throughout the rest of the year. Assuming they had no other medications or cost, this patient would never actually meet their out-of-pocket maximum, but the insurance has now received a total of $15,000 between the patient and copay assistance, alleviating a significant cost burden for the payer. So using the same example, if a patient instead had a copay maximizer plan, these plans work by taking the total amount of copay assistance available, again $12,000 in this case, and splitting it evenly throughout the year. This does mean that potentially the cost burden to the patient is less, but it shifts the cost burden away from the payer and to the copay assistance program. Part of the challenge I think we all feel with navigating these programs is that the landscape changes constantly, and it's different in every single state. So here is a graphic of the U.S. color-coded by the prevalence of copay accumulator policies as of February 2023. So I can promise that something about this has changed. Blue states like mine in North Carolina do have laws prohibiting copay accumulators, but as you go from green to yellow to red, there's an increasing proportion of patients impacted by these plans. And the 10 states that you see in red have more than 3/4 of their ACA plans that have copay accumulator policies. While that graphic represents relatively current state, we know that the use of these programs continues to rise exponentially. So in this graphic on the left, you see the percentage of plans using a copay accumulator, and on the right, copay maximizer. The dark blue represents the percentage of plans actively utilizing these programs in their plan design, while the light blue indicates the additional percentage that have them available but elect not to implement them currently. This number has risen significantly just in the last 4 years, from 2018 having 28% here of our patients having a plan that uses a copay accumulator, and then 44% total having them available, to now in 2022, well, last year in 2022, to 39% of them implementing a copay accumulator, and 89%, so almost all plans having that available in their plan design. Similarly, copay maximizers are being increasingly utilized, and some of this has shifted to higher use of maximizers as states are outlawing accumulators. So to now seeing, as of last year, 41% of plans actively implementing a copay maximizer and 76% of plans having that available. At the same time all of that is happening, as was touched on a little earlier, the cost of delivering CF care is changing dramatically. So this was a retrospective analysis of patients covered by Blue Cross and Blue Shield of North Carolina, so my home state, that looked at both uptake of ETI after its approval in fall of 2019, but it also looked at the total cost of care and resource utilization for both pharmacy and medical claims in a 10-month period afterwards. Not surprisingly, there was excellent uptake of ETI, with 61% of patients at 3 months being prescribed it, and then up to 68% at 12 months. But you can see here when delineating the site of care, not surprisingly, the pharmacy claims increased significantly. There's a 73% increase in those costs, although the authors do note that there was no change in the cost of inhaled antibiotic prescriptions and cost, as well as a statistically insignificant change in Dornase alpha and PERT prescriptions. Also, as expected, there were less hospitalizations that led to lower medical costs, representing a 73% decrease in facilities and then 50% decrease in professional cost. Overall, the total cost of care, despite these lower hospitalizations and medical care costs, increased by 52%. A different analysis that Peter alluded to earlier was done by Prime Therapeutics that looked at the claims from almost 500 people with CF. This analysis compared 180 days pre and post ETI initiation and found that overall increase in cost of care was over $140,000. Similar to that prior study, we saw that medical costs decreased, a 53% decrease pre and post ETI, but the pharmacy cost increased dramatically with a 5.3-fold increase in pharmacy benefit spend. And not surprisingly, we see in the post-ETI period that ETI, which is the purple on this bar on the right, accounts for the overwhelming majority of those additional costs. The authors of this analysis also provided some context on just kind of how do these relate to each other. So they said with all of this claims data in this patient population, they noted that this boils down to an additional $9.64 of pharmacy benefit spend for every $1 of medical benefit savings. And for completeness, which I appreciate, they also adjusted this analysis to account for the copay assistance provided by ETI's manufacturer of $20,000 a year, which does adjust the ratio to $9.02 of pharmacy spend for every dollar of medical benefits savings. As was touched on earlier, there have been many conversations around the cost of CFTR modulator therapy, but after the approval of ETI in 2019, the Institute for Clinical and Economic Review, or ICER, provided their assessment of this in 2020. So first, appropriately, they assigned a superior rating to the clinical effectiveness of ETI when compared to both best supportive care and Tez-IVA for patients homozygous for F508, as well as those with an F508 and minimal function mutation. At the time, they gave a C++ rating or equivalent rating for ETI when compared to Tez-IVA for patients with an F508 mutation and then a residual function mutation, though that analysis did predate the additional data that we now have comparing the two head-to-head. In addition, ICER conducted an analysis that showed the significant cost of modulator therapy is associated with a cost of somewhere between 1.1 and 1.5 million per quality adjusted life year, which is well above generally accepted standards for cost effectiveness analyses. They also went so far, which I thought was interesting, as to model a scenario where ETI completely cures CF, and that's the only remaining cost. And even with that model, the cost effectiveness ratio was $612,000 per quality adjusted life year, which is still well above generally accepted standards. They also provided context that was alluded to earlier about how ETI would need to be priced in order to meet those thresholds. So as was mentioned earlier, that price would need to be lowered by somewhere between 73 and 78% from current WAC or wholesale acquisition cost. They ultimately issued an affordability and access alert because of the potential national budget impact and expressed pretty significant concern about the impacts of these costs and how that would impact the care of both people with CF, but also those with other disease states. And overall, they strongly urged reductions in pricing of these products as well as transparency. To make matters worse, because I feel like I'm the bearer of bad news lately, we've seen an overall decrease in the available financial assistance to our patients. I think as we all well know by now, Vertex decreased the total support available to patients with commercial insurance to $20,000 per year beginning this year in 2023, with 2 tiers of monthly maximums based on whether the patient's plan implements a copay adjustment program. More recently this fall, the Healthwell Foundation Treatment Fund has closed for re-enrollment, but the vitamins and supplements one is still available. For many patients, that was really helpful in navigating the vertex changes, so it will be yet another new challenge for care centers to navigate in the future without it. AbbVie now specifically excludes patients who have an AFP as part of their insurance plan from eligibility to their My AbbVie Assist or their PAP program. And AbbVie, interestingly, has some ongoing litigation with Payer Matrix, which is a commonly utilized AFP. And then this isn't new, but many other third-party funds are often closed and really only open for re-enrollment for brief periods of time. At least in my 10 years in the CF space, Healthwell has historically been the most consistent of the third-party funds. So that pause, hopefully not end, in availability will be significant. With all of those factors working against us and our patients, it is important to look at what's going on to try and combat these payer programs. So earlier in 2023, the Help Copays Act was reintroduced to Congress. If successful, this would require copay assistance to count towards patients' deductibles and out-of-pocket maximum, so fingers crossed. And then more recently, at the end of September, a district court judge overturned a previous ruling in a case that had allowed insurers to not count manufacturer copay assistance towards out-of-pocket cost. That was previously authorized in 2021 by the Notice of Benefit and Payer Parameters Rule. It remains to be seen, obviously, what, if any, impact this ruling has on the payer landscape, but it's a step in the right direction towards lessening the financial burden for our patients and their families. Many of you have been navigating these scenarios on a daily basis with your patients and families, and unfortunately, again, there is no easy solution to many of these situations. We're seeing medication costs rise dramatically at the same time that there has been a reduction in available copay assistance, and on top of that, changes to how that assistance is applied and utilized. When possible, it's important to consider evaluating alternative insurance plans to avoid copay adjustment programs. Self-funded and employer-based plans do tend to utilize these more than marketplace plans and are not subject to the same restrictions. It's obviously not a perfect answer, but something to consider on an individual patient basis. And again, unperfect, but for patients who can utilize available direct reimbursement programs, these can potentially help to circumvent copay adjustment programs and lessen the end result financial impact for patients and families. This is an option that's clearly not feasible for the vast majority, but something worth considering when it is. I'll close with the biggest of plugs for the work that the CF Foundation's Compass Group does. They have been exceptional advocates, both for our center, for individual patient cases, and I know on a much broader scale. If you haven't already engaged with them with your care team, I would encourage you to do so, as they can help you navigate issues impacting your center, as well as work with individual patients to provide help with access-related issues. And I'll look forward to questions at the end.
Thank you. Thank you, Cameron. All right, our final speaker today will be Mary Dwight. Mary is the Senior Vice President and Chief Policy and Advocacy Officer for the CF Foundation. Mary directs the Foundation's public policy agenda and Compass, a team of CF patient advocates who provide assistance services to help navigate insurance, financial, legal, and other complex issues. She leads efforts to explore innovative care delivery mechanisms and alternative payment models that efficiently, effectively, and consistently provide high-quality CF care. Today, Mary's going to talk to us about a changing landscape to improve the cost of CF care.
Well, thank you to Jamie and Ryan for inviting me to talk and for these really excellent talks before me, which hopefully this will sort of tie a few things together. Let's see, what do I need to do here? Quick start, yep. That's obvious. Okay, there we go. Great. So I hope to try to wrap a few of this all together by putting the three great talks before into context in what we're seeing in a larger systemic healthcare system and try to place us where is CF in this broader conversation. Oh, I'll just use the mouse. Okay, I have no disclosures or no relationships to disclose in context of this talk. So I want to start with the role of the Cystic Fibrosis Foundation in many of the components of the talks that we've heard today, and also just how do we operate in this crazy ecosystem that we're all operating in right now, and how are we navigating these changes. So Cystic Fibrosis Foundation's advocacy and policy agenda is really to support the mission of the organization to ensure a cure and care for people with cystic fibrosis. And so much of that depends on ability to access the high quality care provided at the care team's sites of care and all the therapies that they are prescribed. So we work extremely closely with care teams to monitor what's going on out there and how that care can be delivered effectively, and also what opportunities and increasingly barriers are patients experiencing in their ability to access this care. We do this across the spectrum of cystic fibrosis care, from routine and unexpected visits, certainly coverage for treatments, which is such a big piece of this puzzle right now, and also in what's to come, the research and development space. So I think it's really important that in this context, it does not matter how many treatments exist and how much excellent care is available to people with CF through the care centers if people with cystic fibrosis cannot access this care and cannot afford it. Care without undue burden, including the burden of cost, time, and anxiety of navigating all this, is not adequate care. And so much of that really drives the agenda of the foundation's policies. How do we do this? Huge thanks to Cameron, who gave a significant portion of my talk already, and I'm grateful to her for especially explaining accumulators, maximizers, and AFPs, so I don't have to. But also for the Compass plug, I want to say how important Compass is as a tool for certainly helping people with CF and their care teams to navigate through this complex morass, but also critically important for our policy agenda. Compass is our finger in the wind. It tells us what's going on and what's coming down the pike that we're going to need to address on a more systemic level. I will tell you, Compass first saw accumulators. Cystic fibrosis was one of the very first places accumulators came to play because of our high-cost therapies about 5 years ago. And we actually informed some of our large manufacturers what an accumulator was and that they might want to pay attention to this. So Compass is critical for helping us know what is happening on the ground, what is happening with individual patients, with care teams, so we know what else we need to advocate for. And so, as it says, this intake of experience informs our policy and advocacy priorities, and therefore what we are talking to decision makers, policymakers, regulators, payers about. So I also think it's really important that we consider the equity context of our advocacy efforts, and really do take a strong healthcare equity lens and focus to our work. It's not just about numbers. It's not about the number of people with an issue, but also the scope of impact for those who do experience an access barrier, what it means for an individual, and what it may mean for a change in the landscape to come. So that equity piece is critically important to our decisions to engage and what we're advocating for. And also, very importantly, which I think gets us a lot more credibility with payer and other decision makers, is we try to really ground our advocacy in, especially around coverage and access work, in evidence and clinical guidelines. This isn't just because we want it, it's because we can prove how effective it is through data. And that certainly comes through things like clinical trial data, real world evidence, the registry, but also Compass data and many of the studies that have been shared at this meeting and are showcased in posters. So please keep publishing. We use it a lot in our advocacy across the board. So thank you for that. So where are we? I'm not going to tell you anything that you don't already know. But the healthcare system, and Jamie spoke a little bit about this in her talk, in the US is exceptionally expensive, and the costs continue to rise. And what that really means, and the part of it for people who have particularly chronic issues like cystic fibrosis, is that healthcare is increasingly becoming harder and harder to access and afford. There was a recent study out of the Commonwealth Fund just in the last couple of weeks that concluded something that actually wasn't much of a surprise, unfortunately, but that 43% of Americans had been inadequately insured in 2022. Not that they were uninsured, but they were underinsured. They had a gap in coverage during the year, or the insurance that they had would not be adequate if they had an expensive medical emergency or diagnosis. What we know is that the vast majority of people with cystic fibrosis are insured. That's a good thing. But a significant number of people with CF have fall into that latter category of underinsured, finding that their insurance increasingly does not adequately cover all of their healthcare needs, and increasingly that the insufficient plans that they are able to purchase cost more to them. And so I think that's really at the nutshell of what we're seeing in the US. They have insurance, it pays for less, and it has major gaps. And the burden becomes much heavier on people with cystic fibrosis to shoulder more of the cost. This is particularly true when it comes to drug coverage. So all that data that I just showed you before and those headlines, they're true across the board for healthcare. And what we know from research asking people with CF about their experience with their health insurance is that there's no one boogeyman in what makes CF difficult to afford. That it may be for some families, the cost of their insurance is the heaviest burden. It may be for others, the cost of their care center visits is the heaviest burden, that they pile up co-pays to see, you have one for the doctor, you have one for the nutritionist, you have one for the physical therapist, and for others, it's drug costs. The totality of cost in CF is the burden for people with CF, and it depends on the type of coverage you have, where that burden lies. However, it's hard to ignore, as some of the other talks have gone through, the impact of high-cost drugs for people with CF and what that does across the board on their ability to afford their care. And I think what we're seeing in some of the headlines that are up on the screen here and that I'll talk through a little bit more in this talk is that we are seeing signs that the balance of affordability in the US healthcare system is tipping. And that there are indications that the US healthcare system may no longer be able to sustain the increasing costs across the board, and especially for high-cost therapies. So what do I mean, and what are we seeing? Again, thank you, Cameron. You did an absolutely beautiful job of explaining some of the trends that we're seeing in the last several years of some rising tactics designed to address particularly the cost of drugs in CF care, and not just CF. It's important to note this is designed to address rising drug costs, these accumulator, maximizer, and alternative funding programs that insurers are implementing in order to counteract the high cost of drugs. And so these programs, the accumulators, the maximizers, the alternative funding programs that Cameron so beautifully walked us through, are really forms of pushback on the cost of specialty drugs in particular across the board by payers designed to say, we can't shoulder all of this. So I'm not going to go through the definition again, because again, thank you, Cameron. But these types of programs, especially maximizers and the alternative funding programs, we're seeing granularly encompass and the community's awareness of them is also increasing. These aren't, unfortunately, the only tactics that we're seeing. And again, Cameron mentioned this briefly, but in several of types of plans, particularly self-funded plans by employers, we are seeing some payers just simply not covering certain therapies, or institute clinically inappropriate coverage criteria to limit access, particularly to high-cost therapies. So they'll either exclude them entirely from the formulary, or they'll place such egregious clinical criteria that you can't access them. And by and large, we see these actions outside of the scope of regulatory authority, again, in the context of self-funded plans, which are beyond the rules and regulations of many of the laws that protect patients from this type of activity. But unfortunately, in just the last month in the state of Utah, we saw the first time a plan, and I see our Utahns sitting in the audience, a plan try to exclude the modulators from a marketplace plan, which we were able to point out is illegal under the Affordable Care Act, and they reversed their decision. So we need to keep an eye on these things so that we can tell them that that is not okay. This graph shows Compass coverage and reimbursement cases by payer type. So this sort of really illustrates what I was just talking about. As you can see, most of the coverage barriers that we see through Compass are from people with self-funded employer plans. Again, these are a type of employer insurance where the employer chooses to cover their beneficiary costs themselves. And this works really well when the employee population does not have high-cost healthcare. It can save the employer money to do this. However, if employees have people covered under their plan that utilize a lot of healthcare, like people with CF, this can be really expensive to employers. And we see them, again, they're regulated differently, so they, or not as regulated, and that they can give them a lot of flexibility about what they do and do not cover, which again can have serious implications for people with CF on these types of plans. And again, just to reiterate, they have the flexibility to exclude drugs from the formulary or do not have to abide by bans, like bans on accumulator plans. Importantly, the unknown employer plan line in this graph is for people who Compass confirmed were on an employer plan, but we were unable to confirm if the plan was self-funded or fully funded. Okay, so that's what we're seeing. What are we going to do about it? So we see that these market pressures are pushing back on the cost of drugs. It's not just happening at that individual level. There are a lot of federal and state efforts designed to reduce drug costs. I think in the political context, drugs are the hot button issue in the case of rising healthcare costs. If you think about politicians and what you're reading in the newspaper, it's drug costs. It's not the across the board healthcare costs, which to be clear are factors, but drug costs are really at the forefront of the political debate. And so you're seeing more and more interventions or efforts to have interventions into drug costs and how to bring them down. So there's some good news here. We aren't just doomsday talks here. There's some really good news for people with cystic fibrosis as part of the Inflation Reduction Act that passed last year. Next year, in 2024, the Inflation Reduction Act will impose caps on out-of-pocket costs for people with Medicare. This is huge, and we know, and I'm sure many of you know, that for people with Medicare, particularly on modulators, the out-of-pocket cost is an exceptional burden and often a massive barrier to their ability to stay on a modulator because they just simply can't afford the copay amount that they have to shoulder. So it is fantastic news that starting in 2024, there will be an out-of-pocket cap for Medicare beneficiaries. It'll be $3,250 in 2024, and then starting in 2025, it will drop down to $2,000, which is, again, exceptionally good news. And I'm really proud to say that the CF community was one of many patient voices advocating vociferously for this kind of cap to make drugs more affordable for Medicare beneficiaries. Another really important thing that the Inflation Reduction Act did was to create a Medicare drug price negotiation to allow the U.S. government and Medicare in particular for the first time ever to negotiate the price of drugs. It's a little bit startling, editorial here, that this is the first time we are negotiating for the cost of drugs because as I understand it, the U.S. government and state governments negotiate for prices for a whole lot of other things. But anyway, here we go. We're going to start negotiating on drug costs. And it's a big deal in Washington, and particular industries are a little upset about it. And so we'll see how it rolls. But it's just the beginning. So to start, the beginning is that CMS, the Centers for Medicare and Medicaid, have selected 10 drugs for the first round of review. This has just begun underway, and already the sparks are flying. And just so we all know, orphan drugs are excluded from these reviews. So no CF drug is on the table for this first round of negotiation. But it is possible that Creon, because of their volume of sales in Medicare, may be selected in the next round of review in 2027. There's also other things going on, like a whole lot of lawsuits. So we'll see if we still have a Medicare price negotiation in a few years. But so stay tuned. I want it to be clear that the CF Foundation supports the concept of government price negotiation, as we know firsthand how high prices can create barriers for patients. And as has been stated before in this meeting, the existence of remarkable life-changing therapies means nothing without the ability to access them. So we will continue to be relentless in our pursuit of a cure for certain, but we're also mindful that the cost of any CF therapy must be attainable for all people with CF so that they can benefit and it can be sustainable for our healthcare system. So that's one of the things going on at the federal level. There's a lot of activity in the states also. The Mountain West seems to be the hotbed of activity. I am from Colorado and I love to ski, so I wish this was all happening a little more into ski season, since Utah and Colorado are hotbed activities. And at least I can come hang out with my fellow Mountain West folks while all of this activity is going on. So another thing that to watch is the advent of patient drug affordability boards. Again, this is a state activity that we're seeing an increasing volume of. And several states, as you see up here, I'm not going to read them through, have introduced legislation or passed legislation to establish patient drug affordabilities boards, which are basically, there's a variety of shapes and of this kind of effort. But basically, they're an attempt by the states to take a look at drug costs, high drugs, the drugs that are expensive to their states, and say, hey, we want to evaluate if these drugs are affordable or not. Again, I noted that the Mountain West, my personal favorite, is a hotbed of activity these days, and Colorado is the state that is furthest along in this effort, and it has named Trikafta as one of the drugs that is under review for whether or not is it affordable. We don't know what's going to happen with these patient drug affordability boards. And again, lots of focus is really on the state of Colorado right now because they're the furthest along. But at this point, I think our voice and our role has been to make sure that anyone evaluating CF therapies understands the benefit from them and hears from patients about their experience so that they can put that critical information, the clinical information, the patient experience into the context of the evaluation. And I will editorialize right now to say that thus far we have found the Colorado effort, while a bit of I'll use a Wild Wild West analogy, Wild Wild West, because they're kind of building the plane while they fly it, to be a very reasonable one where we've been able to really deliver data and individual stories to shape a robust discussion and evaluation. So stay tuned. We should know more from the state of Colorado in about December or January. I think the really important thing here is, so what? What does this matter for people with CF? So again, lots is happening on the broader market. It's confusing, and it is clearly, again, Cameron alluded to this in her map, an ever-changing landscape. And we know that it's adding time, uncertainty, and instability for people with CF and for care teams. Manufacturers are pushing back on some of the strategies payers are using. Payers are using strategies to try to reduce costs. There's a lot of new programs coming into the mix as it's sort of like each one tries to one-up each other. But at the bottom, and some of the critical safety programs, safety net programs like HealthWell and other nonprofit assistance aren't always available. We know that this changing landscape puts people with CF, adults and children, at risks for unexpected cost, treatment gaps, significant time burden, and anxiety. And we know that is also a burden shared by care teams. So I think the bottom line here is the patient should not be bearing the burden of all of this. The patient should be the reason we are acting to reduce and alleviate that burden so that they can receive the care that they need in a timely, affordable fashion. Okay, I promised not to be just all doomsday again. It's not all bad, and there certainly have been some positive efforts. Again, really want to shout out the Medicare out-of-pocket arrival. That's a huge benefit. But we also have seen some small components. Want to point you to poster 402, because we have seen in Compass that simply understanding this landscape and particularly understanding plan options during open enrollment can help people with CF avoid access issues. And to understand that even if a person doesn't have other plan options, open enrollment can be an opportunity to mitigate issues by having a plan in place. Poster 402 shows that people who called Compass during open enrollment to assess their plans, out of those, only 4% called back during the rest of the year with an access issue, and only 1 called up with the following year with an issue that wasn't discovered when they reviewed their plans in open enrollment. So it just supports the fact of having a plan and evaluating from the outset can really reduce the impact of these payer policies. There have also been a lot of policy efforts, again, at the systematic level, for us to try to reduce some of these burdens. We've had some effective roundtables with insurers in both Michigan and Texas alongside people with CF and care teams to create some best practices for insurance plans, and it was we're excited about the opportunity. And I also want to really brag on this one for the clinicians in the room. In several states, we're seeing an effort to reduce, again, the sort of administrative burden of particularly drugs. I'm particularly excited about this one. In California, we worked closely with California Medicaid on a list of drugs that were used to treat chronic conditions, including cystic fibrosis, that are now eligible for prior authorizations of up to 5 years. I just want to say that again. Wow. 5-year PAs. So because the CF Foundation worked with them and we worked with a lot of care teams in California and California Medicaid, the list includes all 4 FDA-approved modulators as well as pretty much every other CF therapy. So 5-year PAs, right? That's good. District of Columbia is considering legislation like this, and Cameron, good news for you, so is North Carolina. So there's little hope out there. So again, the solutions really need to be grounded with the patient at the heart of it, and they must preserve that essential access to care. I think we're also, I know I'm over time, but we are also seeing some good federal policy solutions. I won't hit on these because Cameron, again, already did it for me. Thank you. And we're also seeing those bans in states. Here's another map for you. I think this one was updated last week. This is a map that double layers both accumulator bans and also some other promising efforts like out-of-pocket caps for insulin and diabetic supplies, another thing that has both state and federal activity. What? Oh, ooh, sorry. There we go. Thank you. The other thing that we watched closely for a long time, and if you've heard me talk before, you may have heard this, there are many states that have special programs for children and adults with special needs, including CF. We work really hard to protect these programs and their funding. They are really important safety nets. So looking ahead, It starts with the patient, it ends with the patient. It also really relies on you all and the care teams to help us know what's going on and the impact of this. I want to flag a survey that will be coming out next year. You've seen data from a previous iteration of the survey from us many times. It's the cost of care CF, a cost of CF care survey. And it's been really essential for us to understand the landscape and also to be effective advocates for people with CF and their care needs. And again, we're trying to work very hard to work with payers and understand their needs so that we can bring them along. I also, through the QR code, want to point you out to some specific resources on Medicare, Insurance 101 for people with CF, and care teams and social risk factors. There's lots of tools because this is a topic that we could talk about all day, but we're not allowed to because time is up. Again, you all are the experts. We need to hear from you to be effective voices for you, for your patients. We really do rely on you to both tell us what's going on, but also to advocate for these things. So if you don't already participate in CF advocacy, please text this number, text NACFC to this number so that you can raise your voice too. It's so important. There's so many different issues that we talk about all the time. And last but not least, another plug for Compass. We're here to help you, individual cases, care team issues that you're navigating, and also that critically important finger in the wind. Thank you so much.
Thank you, Mary. Thank you, Mary. If I can have all the speakers come back up, we'll start a short question and answer sort of session. Just as a reminder, if you have questions, please try to put them in the chat. We're moderating and monitoring that. If you would like to, though, we do have a microphone in the center. All right.
And I think a great place for us to start is actually Rhonda Graff typed in a comment. Is she still in the room? Would you be willing to step up and share your comment directly? Because I could read it, but I'm not a parent of a CF.
Yeah, the
Come to the microphone.
Do you mind coming to the mic?
Sorry.
Sorry if I get emotional. So I have a son with cystic fibrosis. He's 27. And for me, being in research and also being a parent, it is a struggle because over the years we have struggled really hard to afford medications and have foregone some medications to pay for others. But it's hard when you see new drugs come out and yet you're thankful to the pharmaceutical companies for putting their efforts into these drugs, but at the same time, the high price of them. So not to place blame, where does that all come from as far as what drives it more? Is it the pharmaceutical company, the insurance, and their lack of willing to pay or allow that to go to out-of-pocket maximums and that type of thing?
Thank you.
Mm-hmm.
I don't think there's anybody who could have said it more clearly. So going back to some of the questions, one of the first questions, Peter, for you was, how do you feel a shift to more telehealth visits impacts the business case for CF, considering differences in reimbursement, overhead, et cetera?
It is going to impact things. We don't know exactly how it's going to, and I think it's going to vary from organization to organization. So clearly physician reimbursement can vary from inpatient to telemedicine. It can be the same depending on the insurer, but many of the ancillary services can't bill that do telemedicine. And it also gets rid of a lot of the other costs or revenue if you're thinking about help for your center for facility fees and other services that may be provided. So it's a changing landscape and it will be different. I don't know exactly how.
And I think I'm going to do a follow-up comment to that, because in the new reimbursement models, telehealth is being looked at very seriously and is recognized as having great potential. And as I mentioned at the end of my lecture, the whole idea of capitation, that when you receive one payment and then you get to decide the best way to take care of your patients, that can include telemedicine visits, that can include home visits. So if you think that some of your patients, you need to go to their home and help figure out what's going on, you can do that in a capitation model because you're being paid no matter what and no matter how you provide care. So it's one of the really exciting things that's going to come out of the healthcare reform. It's just figuring out how we're going to get there over this next decade is going to be the tricky part. So are there other questions? Also, there is one comment that somebody put into the chat about that they wanted to add that is it Viatris and Caiston are now excluded from AFPs as well? Do you have any?
Yeah, I know several of the manufacturers of specialty products are starting to add language to their patient assistance programs that excludes patients with AFPs from using that. So yeah, I think that's becoming more common. I think AbbVie started, and then others are following suit.
So, yes.
Hi, my name is Jacqueline Davis from Boston Children's. I have a question for you, Dr. Woolridge. As we think towards the next decade or two and changes in reimbursement models, you make a very compelling case for physicians and providers to be at the negotiating table. Practically, what does that look like?
When you say practically, what does that?
As a physician, how would you recommend I get involved?
Gotcha. Okay. So the first thing that I figured out is I had to get myself knowledgeable. And as I mentioned, I, in 20 minutes, condensed down what was an 8-week course for me. There are lots of opportunities, like going to the CMMI website and starting to learn about that. You're also welcome to reach out to me and I can tell you how I've figured out some of this. And then getting to the table, I think it's going to be either your local ACO or if you're part of a CNI, which I'm now in the very bright lights, forgetting the acronym for CNI, but that's the other contracting structure. And then also I've been talking to the foundation, and Olivia's in the audience. I know that the foundation for our CF patients is looking at how do we help guide especially states, in looking at value-based payments for our CF patients. So if you're interested specifically in CF and how to guide that, I think reaching out to Mary or Olivia, Denny, right? Yeah. Gotcha, sorry. Would be a great way to go, and then talking to your ACO.
But I also think getting to know your local leaders and working your way up, who's responsible or who do you report to, who knows about your center, and then building on that within your institution. I know we had great impact in the CF Center on Blue Cross negotiations over physical therapy and airway clearance when we brought that to the contracting people to contract for the entire institution. So you can make an impact.
Mm-hmm. Definitely.
Go ahead.
Ready for All right. I was going to type this, but since you didn't have a lot of questions, I'm not going to say this as well as I want to when I speak it. So I'm going to do my best and I'm going to read a little bit of what I've got so far. So I thought the analysis of the Trikafta cost was fascinating. We actually recently had our students decide a cost of a hypothetical drug that cured HIV, but did not prevent reinfection. So it kind of helped our students better understand what goes into deciding the pricing. And other things that they had to take into consideration were the failed drugs, which I immediately related to Trikafta, right? Because we actually looked at 2 different triple combination products, or Vertex did, I should say. And then also thinking about the costs for the manufacturers to put into developing future therapies, which I just read this morning in the news. Vertex just came out, or is working on that therapy for sickle cell, which is going to be really exciting. So considering some of that big cost that's going behind it, but then also, like you said, it's the patients, right? We can't prevent our patients from having it. I guess any additional thoughts on what's going into pricing or how we're looking at things from a manufacturer standpoint, or is it really more so focusing on making sure that we're having adequate coverage with the insurance? I don't know. You hear the debate everywhere, so I would like anybody's thoughts on that.
Yeah, I mean, I think I will be honest that I think my insight into how, different drug companies pick their prices is probably less. I do think, when we think about especially the changes that have come in the last year, the burden that it's placed both from a financial standpoint, from a time standpoint on care centers, the people in this room, but I think more importantly and significantly our patients has just been it's unsustainable, but it also seems to be something that's never ending. We had a visit from our Vertex representative a couple months into the year, and they very bluntly asked, okay, but it's better now, right? Because we're past January, you've figured it all out. And that to me represented the disconnect between what they think this looks like and how it's actually playing out. It seems for a lot of patients, this is just an ever moving target. We keep shifting the finish line. And I think that makes it anxiety producing and also something that, it's hard for them to predict. How are they paying for this drug this month? Is it different next month? Does what worked this year not going to work next year? We know that for better or worse, the program is not going to change for 2024. So at least maybe we've taken one variable out of the equation. But the problem is, I think, right, this has become a war between the manufacturers and the payers. And in the middle of that war is the people who shouldn't be there, which is the patients. And I think lots of people in this room, the foundation, care centers have expressed that about as bluntly as is humanly possible, maybe reserving choice words. And so, it does, I don't have good answers other than I think the more that we as a CF community can share our experiences. I know, for us as pharmacists, the pharmacy listserv has been a wealth of information just in someone runs into an odd situation. And sometimes someone else has seen it and can offer expertise. And other times it's been things like that's the way that we figured out that the copay assistance is tablet based and that the number of tablets dispensed directly correlates to the amount of copay assistance patients get. Vertex wasn't going to tell us that, but that's something that then is able to be disseminated to others and we're able to think creatively about how to deal with that. So I think it's really important for us to just keep sharing our collective experiences, but how they pick those drug prices, I don't claim to understand.
I think
You
that
have
was
anything to add?
beautifully said. I'm certainly not equipped to say how any drug price is established nor what it should be, although most independent analyses will tell you that it is what the market will bear, and it does not have much bearing on actual dollars spent to develop. And again, what we're seeing is CF is a microcosm of a larger trend of increasing numbers of high-cost therapies. And we are just scratching our way into the era of cell and gene therapy, which is going to be a whole nother magnitude of cost and complexity. And I think at the end of the day, it is really the game of whack-a-mole with the patient paying the price has got to end, with two giant big industries one-upping each other on who can extract the more profit out of each other, with the patient paying the price, literally. So that is what has got to end. I don't know what the drug should cost. I don't know what healthcare should cost.
And what do we target? I think you both answered it really well. It is, that's how I felt as well. It seems like it's a battle between the two, and our poor patients are stuck in the middle, and our providers are spending X amount of time taking care of these patients. So where are the healthcare costs coming from, right? And so it's hard, definitely. So hopefully, and I think you've brought it up very well, the anxiety with it changing, but we do need it to change for the better. So thank you.
All right. We had a great question that just came in through the app. Our 340B pharmacy had a difficult time getting the modulators. Is this normal or something that you all have experienced before?
That can happen. It depends on the negotiation that they have for getting the drug onto to that pharmacy. So not only for modulators, but other antibiotic or casein, things like that, the pharmaceutical company can limit who can distribute the drug. So it can happen that you can't do those drugs.
I'll just say from a pharmacy standpoint, I mean, I think there are a number of folks who have established these programs throughout the years. So, I mean, if there's questions, we can always, as a pharmacy community, connect you to folks with our specialty pharmacies who have walked through those negotiations before for experience.
And the other thing about 340B pharmacies is not every insurance company can use your pharmacy if your hospital established one. So we have a pharmacy, but our patients also may have to go to a CVS specialty or another specialty pharmacy.
So there's a question in here that is quite the question. It is, if you had a magic wand, is there a system that might work? Hang on, it gets better.
Okay.
Universal health care. So I'm going to tackle this one first. Mary, my guess is you're going to go for it.
Turn that microphone.
So from a practical standpoint, there has been, my understanding, and the last time I think you and I talked over a year ago, this idea of universal health care has been presented and has been proposed in a bill called Medicare for All. It is completely dead in Congress and will probably remain dead for a while. There are a lot of advantages, as I said in my talk. Everything has pros and cons. One of the pros of something like universal health care is you now have a very large, as we're talking about this battle between payers and pharmacies. When now you're negotiating with the federal government, because all care goes through the federal government can be a very powerful force to have to negotiate with. So there is definitely, the potential advantage for that. However, it's the federal government, and we know how well or not well the federal government can function. There are some really good books about the bill that really outline very nicely. Like if you Google Medicare for All within your whatever you purchase books through Amazon, Barnes and Noble, you'll be able to find some of these books. They're on audio if you're at all curious. So that's a more practical answer.
I do not have a magic wand, nor the answer. But one other thing I would add to the mix is, particularly when you look at the U.S. healthcare system, the sheer number of players in the mix it's significant, by magnitudes greater than any other healthcare system, and it certainly contributes a lot to the cost of our healthcare system. And I think so simplifying down the just pure number of players making money off of U.S. healthcare, I think is an answer. Whether that is Medicare for All or universal healthcare system or something else, I don't know. I do think that there are some very more practical, tactical pieces that probably won't emerge from this dysfunctional Congress, given that it couldn't even operate itself for 3 weeks. But I think there's hope for it maybe in next Congress. And I kind of flew through it, and Cameron addressed this in her talks too, things like the Help Copays Act. And I'll brag about the CF Foundation's advocacy, particularly on some very technical but important reforms for PBMs, pharmaceutical benefit managers, trying to extract some of the redundancy and again, very technical but sort of add-ons that are operating in lack of transparency in that system. I think there is a chance for those to pass. I'm looking at Teresa like maybe that might get through this year, maybe. And like it's incremental, but it actually would be significantly beneficial to start to get more clarity, transparency, and patient focus into the mix. So get out the superfluous players, focus on the patient, focus on the care that needs to be delivered. I don't know how we do it, especially in this political climate, but I think that if I had a magic wand, it would go towards that.
Yeah, and one follow-up statement. When you start getting into data such as numbers and finances, I have found that I grew up thinking a number was a hard, cold fact. When it comes to finances, you get there's so much variation in how you interpret things. But with that said, I have seen data that if we had a more universal healthcare system and we could eliminate prior authorizations and get nurses instead of on the phone with insurance companies actually taking care of patients, that the cost savings would cover a good majority, if not all, of state Medicaid budgets.
5-year PAs in California, right?
Go ahead.
Hi, Adrienne Savant from Tulane Children's Hospital in New Orleans. I have two questions because you made me think of a second one. But the first one is for Dr. Mogazel. It was on your slide. It was one little thing about not getting double discounts, and I was wondering if you could explain that more, because we got a 340B pharmacy, and they cannot give our patients their Vertex medication, so there is no financial benefit for us. And they've told me it's because they cannot double dip on their discount. And so I don't know if you can help, because I think this could happen to other people, and I think it's an important, or my hospital's telling me the wrong thing. One of the
Well, I'm not sure it's the double dipping part of it. As I said, Vertex can control who provide or who dispenses the drug. But my understanding is that the discount is supposed to be the only discount that you get on the drug. So the copay may be a problem if you're dispensing it from the 340B, but I'm not 100% sure about it, to be honest with you.
Yeah.
Yeah, so they told me because they get a Medicaid discount, they cannot then dispense it to my patients, and I have 80% Medicaid. So they already get a discount from Medicaid. They can't take a discount from
That's what.
Okay.
So most specialty pharmacies, they maintain, so if you're 340B, you have to have two separate supplies. Now, some pharmacies do that like physically and pull literally from two different stocks, and others have tracking systems. That's how they maintain their 340B eligibility. But so Medicaid, they do have to pull from two different supplies. So it's not impossible. It just creates additional like administrative burden.
Okay, I'm gonna talk to you more about it
Sure.
later.
Yeah. I can connect you with our specialty pharmacy. That's the extent of my
I was all so
knowledge.
excited because I've been told for a long time this would be a moneymaker.
Yeah, well, it does. You also do, the other drugs also have a margin too, beyond just the modulators, because modulators
They
are
won't
large.
fill any of our Medicaid patients, and we have 80% Medicaid, so I don't use them at all. So I'm just saying.
That's unusual. So
Yes, thank you. Okay, I'll talk to you later about it. The second thing is just to go more practical. I'm trying to be more practical because the rest of it sort of scares me. How do the rest of the states try to work toward that 5-year PA?
So I think it's something that's really kind of nascent in states' considerations. But again, we know both North Carolina and DC are considering it. We have worked with. I'm looking to my team to help me. I think it's the AP that we've worked on model legislation. AMA, thank you. The American Medical Society. We worked with them to craft model legislation on this kind of longer term prior auths, and we are happy to work on that because we think it is helpful.
All right, I've got two more quick questions. Mary, I think this one's directed for you. How do we help in our area to get the state to review drug affordability?
Well, I think this is another one that's sort of gaining momentum. There are numerous states that are considering it. Whether I will say, I think our verdict is out on how helpful it will be, especially with each state having a different format for it. And again, thus far in the states that are implementing it, we've seen different approaches in each state. And it is definitely building the plane while it's being flown. So I think our verdict is sort of, okay, it's good to talk about this cost and it's good to have these conversations. What are the ramifications actually going to be? And is it really going to achieve the goal that's stated? I don't know. So at this point, the position of the foundation is we will engage and be proactive to ensure the needs of people with CF and the needs of patients with high cost therapies are reflected in the structure of these boards. But we welcome the conversation, but I wouldn't say we're at the point yet of like, merrily we barrel down the road.
And I'm going to add another comment to that, because Mary, I think it was something you got me into. So one of the things that, and this has been a few years ago, Mary had approached me about, and I had no idea, is that if you go to your state website, your state Medicaid website, start looking at what kind of committees and leadership it has. I found out that New York State Medicaid has a drug utilization review board. And I found out through the foundation because they said, hey, we really need somebody who can advocate for CF on it. And I have found that I've actually advocated for COPD, I've advocated for asthma, and had a major change with smart therapy for asthma patients. And it was a committee that's always desperate to have knowledgeable people on. And it's been something I had no idea about. So that may be another thing is that you may be able to, start to have some more say within your own state just by getting on a Medicaid committee and seeing what's actually happening in the discussions and helping lead discussions.
Can I add to that? Because yes, thank you for reminding me. But I think our most effective advocacy comes with relationships, no surprise, right? But in the states where we have care teams who have direct relationships with their Medicaid, and we are able to serve as advisors, both the foundation and the care teams are able to serve as advisors when Medicaid in particular is considering something different for CF. We have found that to be our best tool all the time. And so some of the, I think, more systemic ideas like the affordability boards, again, as I said, the verdict is still out. What we know works is when they know us and they consult us when they're considering cystic fibrosis. So I gave the example of the California Medicaid. That's because the care teams worked with us, with Medicaid, to make that list and make sure it got through. Michigan is another one where we have a really fantastic relationship with the state Medicaid agency where they contact the care teams and they say, we're thinking about this. What do you think? How should we do this? That's really, I think, for CF, and they know us because we happen to cost a little bit for their Medicaid agencies. Those are where we find the most effective decisions made around CF coverage.
All right, I realize we're right up against time. One final question. What does the group feel is the best way to support positive changes in regards to patient costs at an individual level?
Get involved in advocacy.
That's a good answer.
Yeah.
That's a good answer.
All right. Well, thank you, everyone. Thank you, everyone, for coming. And thank you to our speakers for the excellent messages and responses today.